All right, well, it's 7:03. We have almost 30 people, so I think it's a good time to get started. So I'm on this slide, everyone, with the activity code 59YLEM to get your CME. And so welcome to our penultimate NESR meeting of 2021. We're joined here by Dr. Newsom, who just finished a case and joined us. So thank you so much for joining us despite an incredibly busy day and week, it sounds like. So it's greatly appreciated. Dr. Newsom is an associate professor of radiology and division director and chief of interventional radiology at Emory University. Prior to joining the faculty at Emory, Dr. Newsom worked in private practice in Virginia for 15 years. She attended medical school at Mount Sinai and then completed her residency in surgery and diagnostic radiology at Medical College of Virginia, Commonwealth University in Richmond, Virginia, and her fellowship in IR at Miami Cardiac and Vascular Institute in Miami, Florida. Dr. Newsom's interests include uterine fibroid embolization, interventional oncology, vertebral augmentation, treatment of DVT, pulmonary emboli, and peripheral arterial disease. She's very active in a lot of our IR societies, including SIR, the Southern Angiographic Society, and the ACR. And she recently became chair of the International Education Exchange Committee for the Society of Interventional Radiology. Dr. Newsom's an accomplished researcher. She's over 25 citations on PubMed. We are honored to have her join us tonight to speak on IR trauma, IR management of trauma. And so one quick aside before she starts speaking, if you do have a presentation, we have a couple at the end cases, you can just message me privately in the chat box. So we have Dr. Newsom here and welcome. I'm gonna stop sharing and you can screen share.
Thank you so much. Let's see if we can do this again. Share screen, share desktop #1, share. Okay, look at that. And then we'll go ahead and start that presentation. Are you able to see the screen now?
Looks great, yep.
All right, fantastic. Okay, so I am honored, I'm humbled and privileged to be here talking to all of you tonight. I want to thank my friend and brother, Dr. McGinnis and Ezra and the entire New England Society of Interventional Radiology for asking me to come and speak today. This is a topic that is near to my heart, maybe because I grew up in Jamaica, where trauma, or that word was just something that stole a lot of my friends and family along narrow roads there. So I've come to appreciate exactly what that means, and I'm honored to be speaking about that. So over the next 30 minutes or so, I think I'll try to paint a picture of what trauma care is in the US. And like today, I would say that we're in the pandemic or intra-pandemic. I'd like to talk a little bit about how the pandemic have shaped some of what we know about trauma and interventional radiologists' role in delivering this kind of care. So I don't want to use my voice today to discuss things that can be found on laminated cards or in reading rooms, such as the grading system for liver or spleen injuries or the type of embolics, or even much about trauma statistics, because I believe that Google will do a much better job than that. So what I want to do really is to use my voice to touch on a few things, review some cases, specifically some related to pelvic trauma. And I want to use most of my time to identify some of the disparities around trauma and trauma outcomes and touch on what are some of the opportunities for the future. So I do not have any relevant financial disclosures, although I am a strategic advisor for Boston Scientific, the Interventional Oncology Division. And this year, I took over the role as the co-editor-in-chief of TVIR, and I am really, really excited about that and looking at reshaping that journal in the next few years. So every time I speak, I think people are just so tired of seeing this. That is that I happen, that's my disclosures. Okay, yeah, I did talk about my disclosures. I happen to to work with just some of the most incredible interventional radiologists here at Emory. I'm challenged every day by them. I think I work with some of the smartest, not just faculty, but APPs and residents. I am privileged to be the division director here and work at Emory across 4, soon to be 6 different hospitals, a children's hospital and Grady Memorial Hospital. And you'll see some of what the breakdown of the beds there. But I want to talk a little bit about Grady, which is an almost 1,000 bed level 1 trauma center. It's our 5th largest public hospital in the United States, and one of the busiest level 1 trauma centers, in the country. So serious trauma patients are routinely brought to Grady from all neighboring states, and we share faculty with Morehouse School of Medicine to serve some of the sickest people, not just in Atlanta, but around the area. And it is because of Grady that I do not get that much sleep at night. It is because of Grady that my hair is a little bit browner or grayer every time you see me. It is because of Grady that I make several renditions of the schedule as the chief every day. And it is in this environment that I live and I breathe, and I say that I have my being. It is in this environment that we test the limits of medicine by innovating whatever the existing standard of care we think is, and come up with novel ways of saving patients' life. And so trauma is what I do. I grew up in church, and there's a song that says, praise is what I do. And I literally will say that trauma is what I do. So let's talk a little bit about trauma. So I'm not sure, who's in the audience, but I was told that there would be some junior trainees here. So this is not so much for the seasoned faces that I'm used to seeing, but we know that the landscape for trauma, is still the same. It's the leading cause of death for young people in the United States and worldwide. Globally, it accounts for around 10% of deaths, and that's around 5 million fatalities. In the United States, we'll say that 45 million people are disabled globally. There are around 50 million trauma-related visits in the United States, and around 30% of all ICU admissions are related to trauma. And that's a lot of trauma, one would say. And trauma in the United States cost. So it's clear that traumatic injuries take an extraordinary toll on our society. And besides cancer and heart disease, it's the 3rd most expensive category of healthcare treatment. It's estimated that $670 billion is spent in US healthcare costs for trauma, and it remains a real public health crisis. Yet there's just not a lot of research that is put into trauma. While there have been much advances in trauma care over the past decades, we know that there's still knowledge gaps. And if we can close these gaps, we may actually prevent some deaths. So the most preventable death as a result of unrecognized or untreated injury is a hemorrhage. So simply put, would say uncontrollable bleeding is the most common cause of early trauma-related mortality. And that happens in around 30 to 40% of cases. And mortality rates have been improving over the last decade because we have good integration of multidisciplinary team, faster imaging. Like every day I look, there's like a new gazillion slice scanner being put in somewhere. We have increased expertise at level 1 and level 2 trauma centers, but we know that traumatic injuries continue to have significant mortality and morbidity. And we know that we can decrease these levels of mortality if patients are treated at designated trauma center. Even at my state-of-the-art trauma center at Grady, we know that there are opportunities still to improve outcomes, and we must still try to find better and better solutions for controlling hemorrhage. So while the treatment of trauma may vary from one site to the other, we know already that controlling hemorrhage, that's the name of the game when it comes to saving life. So what is the role of interventional radiology? Over the last 20 years or so, transcatheter arterial embolization for traumatic injury has played a real pivotal role in decreasing operative blood loss and improving survival, and definitely improving morbidity. So I know we talk a lot about mortality, but I also want to touch a little bit on morbidity. There's no denying, Shams, that embolization is effective. And we can do that in multiple areas of the body. We do it all over the body for different things. There's no denying that the expansion of the indication of IR in trauma, and that this is happening more and more every day. And many, many centers, including my own, keeps pushing the criteria, which I believe for the betterment of patients. So over the last 20 to 25 years, while surgery have seen operative management for both blunt and penetrating trauma go from 100%, like everybody went to the operating room with their associated morbidity and mortality, to now where over 90% of patients are being treated with minimally invasive techniques. Oh, thank you, interventional radiology. This is a monumental switch and a huge deal for patients, especially patients that have multiple trauma. And almost every single society that is out there that looks at trauma definitely say that interventional radiology have some role somewhere in the algorithm as it relates to blunt trauma, some penetrating trauma, and for sure, pelvic trauma. So the immediate care of trauma patients definitely mandates a multidisciplinary approach. I'm not here to say that we're the end of it, right? We know that emergency room physicians, critical care doctors, trauma surgeons all play a role. And I am proud to say that interventional radiology also plays a pivotal role with the primary goal here to stop bleeding and to prevent the consequences of bleeding. So at trauma centers everywhere and every day, IRs are pushing the limits. We know that there's a traditional model, and I had to absolutely give the shout out to Dr. Dotter as the old traditional model, and definitely to say that we're looking at an evolving model where we're not just taking care of patients that are hemodynamically stable, but pushing the limits for hemodynamically stable, unstable patients with known pelvic fractures, and hemodynamically unstable patients where we can see that there are deep vessels that are injured, or anytime we see extravasation on imaging. I don't think anybody can deny it. It is true that interventional radiologists have taken trauma care from the Stone Ages to, I'm not sure what age we're in now, the jet ages, but we're definitely there. And the intervention, while I won't go too much about there, we know it's largely dependent on the organ that is injured and the degree of the injury. And people debate this, and I've seen this all over the place where, okay, is the most commonly injured organ the liver or a spleen? I would say we think that maybe it is the spleen, although a lot of people are thinking that it is sometimes the liver. But the treatment, regardless of if it's the liver or spleen, are not always the same. Liver, spleen, or kidneys, or what we think are the most, the solid organs that are injured in the abdomen. And there are several organizations, namely the American Association for Surgery and Trauma Injury Grading System, that categorizes these solid injuries based on the degree of hematoma, laceration, and vascular compromise, or the World Society of Emergency Surgery guidelines, which actually stratifies the ASD score with hemodynamic instability. And those go from mild, moderate to severe. And again, I'm not here to really talk about the scoring system, but really because I'm a radiologist and I'm an interventional radiologist, I like looking at pictures. And these pictures actually show really what a grade 1 injury would be to the liver, something like the laceration as small as my nail, and a grade 2, which is a little bigger, 1 to 3 centimeters. No, none of us like to see grade 4 or 5s where it's clear that there's parenchymal disruption or vascular injury. And now I know that there's even a grade 6 where hepatic avulsion is seen. And yes, We have these laminated in our reading rooms where, most of our diagnostic radiologists is able to, tell quickly on the CT, was this a grade 4 or was it a grade 5 or was it a grade 2 or a grade 3? But the real schematic part for us is the proposed management protocol. And if you look at this clearly, you can see that on your management protocol that if the CT shows any extravasation or pseudoaneurysm at all, then this patient is coming to angiography or embolization. And if it isn't seen and non-operative management is chosen and the patient drops their H&H, then angiogram is also going to be done. I want to turn your attention to the hemodynamically unstable patient where we still believe that maybe surgical management is not a bad thing, but almost invariably we're seeing more and more patients after surgical exploration will still come back to interventional radiology for embolization. Let's take a look at a case of a 29-year-old with a penetrating injury, gunshot wound to the right flank. The patient was, hypotensive, tachycardic, but talking with a ballistic fragment in the upper abdomen. And you can see that, the patient was tender to palpation, went to the operating room and had a, major operation, but still they were unable to control the liver bleed. So a patient like this is not uncommon. This patient is absolutely coming to interventional radiology. An angiogram was done from the femoral approach, and you can see here 2 clear areas of abnormality in the liver with extravasation and with selective catheterization of the right hepatic artery. Actually, you can see a transection with extravasation. What to do? Check your own pulse. And this is someone that is absolutely right up our alley for helping. So this patient actually underwent, I'm sorry that this is repeating, glue embolization for the area that is transected. And because we were not able to more selectively catheterize the other areas that were bleeding, gel foam embolization was done. This patient actually did really, really well, and you can see those pre and post images and on your screen. And so, yes, even in patients that have gone to surgery, interventional radiology is there helping to improve survival and outcomes for liver lacerations. I want to show, another case involving the spleen. And we know that injury to the spleen is very common. And some people say that the spleen is the most common organ. The precise role of splenic artery embolization in blunt trauma remains very controversial. And we know that at some institutions, surgery is still being done or just pure non-operative management of bed rest. Stable patients with low-grade injuries, I think, could still be treated conservatively. And patients with moderate or severe injuries, like grade 3 or 4, there's a grading system for splenic injuries as well, have been shown to benefit from endovascular embolization. And there are high rates of preventing splenectomy if splenic embolization is done. So most recently, they've added like pseudoaneurysm and active extravasation to the grading system of splenic injury of the AST injury to be grade 4 and 5. And please, again, I'm not here to try to go over these grades, but let's look at a case of a 56-year-old who had a motor vehicle crash and a grade 5 splenic injury. The patient was transfused and was found to be more stable, and then came for angiography. Again, from a femoral approach, you can see the areas of extravasation within the upper pole of the spleen. And this patient was treated with coil embolization. And I know exactly what Herschel is thinking. He's like, Newsome, what are you doing? What about proximal embolization? Why are you doing these selective embolizations? So let's talk about that. So, there are 2 types of approaches to these splenic injuries, whether it's proximal or distal splenic artery embolization. Proximal embolization of the spleen is faster. We know that reintervention rates are low, and it absolutely works. It is done and decreases perfusion pressure to the spleen and allows for viability of the spleen through collateral pathways. And distal embolization is only done and is used when focal injury is seen, as in the case that I presented previously. And there have been some reports about higher rates of abscess and infarction in distal embolization. So please do not kill me. That's just what we did that day. So I showed two cases of how transarterial embolization, we know, has really been, played a pivotal role in trauma. We know that it works. We know that it's effective. We know that we can absolutely do it. We do it in the liver, kidney, and spleen. I haven't shown you a case of kidney embolization, but it is pretty much very much the same. And we know that anywhere that we can place a catheter in a vascular bed, where it's hard for surgeons to be, that we can absolutely do it. But I can't think of anywhere else that it is most useful than in the case of pelvic trauma. So pelvic fractures, we know, carry highest mortality of any skeletal injury, up to around 16%. And timely identification and control of bleeding is pivotal in reducing that mortality. And if you've ever been in one of these cases, you absolutely know what I'm talking about. So the biggest impact for minimally invasive procedure, I think, in trauma is in the management of pelvic trauma. And where this differs from other blunt or even some penetrating solid organ injury, this is where IR lives, and the primary place for patients with pelvic trauma, instability or stability, is for patients to be undergoing angiography and embolization. Because we all see that pelvic ring, and we know that that same red ring, if that patient goes to trauma, it's going down a rabbit hole of packing and pre-packing and post-packing, and then still come into angiography. So let's talk about, I just wanted to show this image for some of our young students, learners in the audience, that yes, you can see that where the pelvic ring is disrupted. And this patient did not have angiography, just placement of a pelvic binder. And I put this slide up here to remind myself as to the importance of having pelvic binders in the treatment, and to talk about how pelvic traumas are mostly venous in nature, right? 9% of all blunt injuries, motor vehicle crashes, have pelvic injuries, and that most of the patients are indeed hemodynamically stable. And most of the time when there's bleeding, it actually is a venous bleed. But when patients are hemodynamically unstable, most of the time, 70% of the time or so, those bleeds are going to be found to be arterial. And so I tell my trainees, and I remind myself really, that the name of the game in saving someone with pelvic trauma is really knowing where you're going. The vascular anatomy here is going to be crucial. And yes, knowing this anatomy, we're all in this space, whether we're dealing with uterine artery embolization or prostate artery embolization. And I'm reminded here that when you've done all of that, you need to still remember variants, that this corona mortis, which is a common variant that talks about the anastomosis between the external iliac artery and the internal iliac artery via the obturator artery, is something that we need to pay attention to, because ignoring this while we're doing pelvic embolization can be very costly. So here's a patient, a 66-year-old, with a comminuted fracture through the inferior pubic ramus, and you can see the active extravasation here. One would think, okay, is this patient going to do okay with nothing? This patient actually had binders on, and we went ahead and could see this active extravasation from the left internal iliac artery. This patient had gel fold embolization and coils. And yes, extravasation can be seen in some patients. And when we don't see extravasations, we will use secondary signs such as transections, where there's an abrupt cutoff of the vessel, and still perform internal iliac artery embolization. Most of the times we're doing superselective embolizations because you can go to the site of injury, but non-selective embolization can be done of the entire internal iliac artery branch if the patient is hemodynamically unstable and there are multiple sites of injury. So for pelvic trauma, and this is what we do in Agredi, our guidelines, we see where interventional radiology, and angiography is in every single pathway. It is in patients that are hemodynamically stable, patients that are hemodynamically unstable. We play a vital, vital role in these patients. I'm going to switch gears a little bit to talk a little bit about, yes, in pelvic embolizations, we save a patient, and yes, we think that we're the true superheroes. And this reminds me quite a bit of this word superheroes is something that has been thrown around in the media, especially during the pandemic, but we've been called superheroes before in the setting of trauma. But let's just talk a little bit about what we're seeing now in terms of trauma and the pandemic. One of the most profound and necessary things I believe that happened over the last year or so was in response to COVID-19 with these stay-at-home orders and the shutdown that happened in our country and internationally. And with that shutdown, I would say, generally speaking, folks said earlier on, at least, that the incidence of trauma went down, and most trauma centers saw that reduction in trauma. At the same time, I would say that most of the trauma leaders were reporting an increase in other types of trauma, domestic trauma, recreational and pediatric trauma, with some specific mechanism of injuries. There was a few retrospective studies that have looked at different cities in the United States and some hotspots as it relates to trauma. We know that in California, for instance, they reported some decrease in trauma, and in Texas, I would say that I didn't cut out the article about that, but here in Atlanta and at Grady, we did not see that at all. We saw something very similar to what is happening in Philadelphia, where we saw that the incidence of penetrating trauma actually went up. And I'm sure this was not an isolated occurrence. Gun violence itself has been an epidemic that superseded this particular pandemic. And now that people are staying at home and they're shut down of business and there's this whole economic crisis, this only perpetuates what we see in this violence epidemic. So Philadelphia, like it is in Atlanta, had one of the worst gun violence in March of 2020 for the last 5 years. And in the United States, saw more background checks that were performed from March of 2019 to March of 2020, that it was estimated an increase in around 90% of gun sales. Now, some of these could be other social things that were happening, but that is exactly what we were seeing here. So this increased number of guns in circulation at a time of high stress really have had unintended consequences. And this keeps me up at bed, from sleeping all night long. So specifically related to the pandemic, I would say that, at Grady, we were really, really challenged and still are dealing with some of these challenges as we require testing, but testing availability was really sparse. And are you waiting for results to come back? What about PPE, and how are we going to deal with that for limiting care? We know that, some parts of our hospital were just turned into testing sites. And what we had to do was just assume that most patients are positive due to the high prevalence of false negative tests. And we are actually still doing that. We know that earlier on, there was just a lot of misinformation about COVID-19 and what type of face masks were we allowed? Were there N95s or KN95s for anesthesia and interventional radiologists? And I would say that one of the biggest impact that we had here from the pandemic were just blood shortages, and massive transfusion protocols really suffer. And social distancing actually limited a lot of our blood drives, and our trauma center took a hit. Now, the recognition that traumatic injuries must be addressed as a public health epidemic rather than just unavoidable accidents have led to this expansion of trauma centers. And it's recognized that we must bring patients that are critically ill to advanced trauma centers to improve their outcome, so-called comprehensive trauma systems. Many studies have shown that there are major inequity in access to trauma across the United States, especially in the rural areas. In addition, we continue to experience closure of trauma centers all in the United States, which is another growing national crisis dealing with emergency care. Trauma centers, moreover, are likely to be safety net hospitals and are underfunded and are likely to be poor and non-reimbursed for their provisions of this life-saving but expensive care. Now, with this backdrop of facts, if I told you how trauma intersect with our ongoing pandemic, I think that you would understand it. So in JAMA of 2019, researchers at the University of Chicago and Stanford compared the distance from your closest adult level 1 and level 2 trauma center in Chicago, New York, and LA neighborhoods to various racial and ethnic compositions. And what they found were that people living in the Black majority neighborhoods in Chicago were more than 8 times likely to be in a trauma desert compared to people in a white majority neighborhood. And in LA, they were 5 times more likely. And in New York City, they did not see any demonstrable difference, this level of disparity across trauma centers, likely because the city has an extensive network of trauma hospital. Now, this finding is very worrisome because living in a trauma desert is associated with longer transport times, higher mortalities after a gunshot wound compared to neighborhoods where you're closer to a trauma center. So it's not just that, do I have interventional radiologists or do I have the latest and greatest technique? That morbidity and mortality, sadly, is also related to what zip code do you really live in? And for Black Americans that are disproportionately likely to suffer injury or death from firearm or a homicide, we know that there are studies now that show that up to 59% of gun homicide victims are Black, despite only being 14% of the population, and 57% of Black Americans know someone that has been shot, versus 42% of Hispanic and Latinas and 43% of white. And in Chicago, California, and yes, here in Atlanta, and I'm sure in your neighborhood, the disparities in gun homicide deaths by race and gender is actually quite astounding. However, to reduce this racial disparity in gun violence death, even more meaningful, we need to target structural causes of violence as well as access to medical care. Structural violence refers to the harm caused by poverty, racism, and lack of educational opportunities. This is endemic in our communities of color. And the lack of investment in trauma centers and social determinants of health in underrepresented minority neighborhoods are partly due to the way some neighborhoods may be portrayed sometimes by the media. So there's a lack of empathy or an empathy gap as to who is deserving of this aid. And this leads to more and more neglect. So let's be frank, for years we know that the community, our community, the communities that we live in have largely overlooked people that would benefit the most for some of the most exciting care that we provide as interventional radiologists. But we must evolve to serve the unique needs of people, all people, people that are LGBTQ, people of color, people living in housing instability, immigrants, to name a few. And I am privileged and very fortunate to be here in Atlanta and working at Grady Hospital to be able to provide this care. And we know that these inequities have been around from the beginning of times. But yes, we must consider that now may be the time for change. And yes, technology has a role that it must play, and it will take us on roads that will help us to treat patients. We are becoming smarter, and technology is helping us to become smarter. At Grady, for instance, we know that our pre-ambulance transport have a lot of technology that is exceptionally wired and tell us a lot of things about patients before they actually even arrive. And in our angiography suites, there's no shortage of new coils and new wires and catheters, etc. And we know that healthcare and this type of healthcare is what we absolutely live and die for, where we're using technology as an opportunity and not as an obstacle. And because I know that where I live and where you live is not just where you deliver care, I happen to believe very, very strongly in what we do as interventional radiologists, and that what we do every day improves health and definitely save lives. And so it is our job to be able to take this type of healthcare all around the world. Our willingness and our ability to actually do this, to learn from our failures, to build on some of the things that we have done wrong in the past, and to strive for a system that is fair, a system that is not just about one place, but that is world transformational, not just one that is about building the best practices in New England, but also building the best practices in the Southeast, that we could transform trauma care in the United States. And indeed, we can survive and thrive and go from trauma deserts, yes, to where we're building caravans of care. I want to thank you for your time. And I am going to stick around to see the presentations and definitely to answer any questions. Thank you.
Wow, Dr. Newsom, that was incredible and so inspiring. Thank you very much. I loved how you went from, as small as the role of IR, although it's big, but the role of IR all the way up. So that was really inspiring. Thank you. One thing I was curious about is you talked about trauma deserts in terms of cities, hospitals being located in different neighborhoods, but I was curious about rural areas also, because I've read about doctors not wanting to practice in these rural states and them having difficulty having specialists go out. So I was wondering if you could speak to that problem also.
Absolutely. In fact, that's one of the original trauma deserts, and I think that there have been many, many papers that have been written around that. And Ezra, it's very, very sad, and I'm not exactly sure what to do with it. So big trauma systems like we have here at Grady, we've set up partnership with rural hospitals to say, okay, fine, you don't have to do anything. When this happens, we just send the patient to our center. But we know that each of those seconds, each of those minutes are actually, we're losing precious time to make an impact. And so until we have more investment in research and more investment in the government, from the government, to save rural hospitals, or to find ways that rural places could connect with other main trauma systems. And I'm using that word especially, and not just trauma centers, because trauma systems really not just take care of this immediate thing, but actually takes care of the entire patient. They're able to figure out, does this patient need social services? What kind of rehabilitation is needed? Some trauma systems actually have occupational type help afterwards. They have social workers inbred, because if we're just taking care of our little part, saving this patient's life, but then they're just going to come back in, or they're not having any quality of life, then we're not really doing anything. And so it's challenging, because trauma care is expensive care, and a lot of rural places just are not able to afford it. So I think I'm not answering your question because I don't have a good answer.
Yeah.
I would just say that, yes, we're aware that trauma deserts are more in rural areas than in other areas.
Okay, thank you. And I have a question from Li Wei Jiang, who's one of our fellows. I actually had a similar question. And he's asking kind of, what is the optimal level of staffing, especially for a hospital like yours with 1,000 beds? I worked at Boston Medical Center for my prior job, which was a level 1 trauma center. And, it was a challenge with, what is our pager response time? How is the IR team called in? What's the call like for a massive hospital like yours? How do you do that?
I deliberately stayed away from that subject, but okay. I knew, Ezra, you were going to bring that on, right? And whoever, definitely. So we're a massive practice. We're 33 interventional radiologists at Emory and Grady, but we cover a big area. And I don't know what is the optimal number of people for covering 1,000-bed trauma centers. I would just say that we have layers of people that are on call. And so there's a primary call, there's a backup call, and then there's a backup to the backup call. And Herschel knows because he'll talk to me and I'm like, I'm on call again. And he's like, you're on call the most, right? But when all else fails, we're here. So there's a different system that responds to just every night call. We always have one person on call and a backup person to that person. But every time there is a all-star game, we have to go into major crisis mode, and then we have 3 people on backup call all the time. When there are demonstrations downtown, we have a backup call. Whenever there is a Beyonce concert in Atlanta, there's there's crisis mode call. So what is the optimal staffing? What we have done is that around the beginning of the pandemic, Ezra, we went to a different call schedule for our practice. And so we treat call at Emory for the faculty like night float. And so that is that person's entire responsibility. Now that comes as a cost, but it was one that I was willing to fight. And so when you're on call at night, you do not have to work in the day. And we're transitioning the same night float system for our trainees to accommodate the trauma care at Grady. And that was one of the main impetus for that.
Thank you for that response. It is a very different environment than I've heard of before. It's such a major center. And as division chief, it must be very difficult to make the schedule, I could imagine.
Near impossible.
Yeah.
Ezra, can I just speak up in response to that question?
Yeah.
So I think solving this problem is vital. We started off talking about the transition of these patients from going from surgery to IR as the standard. Dr. Newsom said openly, this is what wears on me the most, is taking care of these trauma patients. We also know from interviews with medical students choosing specialties that 70% of women in medical schools and 30% of men in medical schools won't consider careers in IR because the rigors of the specialty aren't conducive to them having families. And almost everyone I talk to who's a practicing IR who retires, I'll say, why are you retiring? They say almost uniformly, the call is burning me out. I think it's incumbent upon us to really do some deep dives into making this discipline more humane on us as a practitioners. If we're going to increase the diversity of this specialty, and if we're going to retain mature talent, to find a way to deliver this care in a way that doesn't burn people out. And Neil, I'd be interested if you had done any experiments in your division to make the impact of call maybe a little less intense.
No, we haven't found the magic secret. I was actually going to say that when your hospital, and I should say that anyone that practices in a trauma center, of course, needs to be on the trauma committee to represent IR. But the hospital administration, I think, would have no problems if they have no problems when a surgical specialty such as trauma or one of the other ones comes and says, you need to pay for enough people that we have someone in-house 24/7. And for weekends, you need to pay so we have enough staff so that people can work the weekend but not work 2 days during the week. And I would say that in most hospitals, if IR went, and when IR goes, they would just look at me and give me the Labrador Retriever look, which is, what are you talking about? That's sort of the response we got when we went and asked for backup nursing. So the techs work for radiology. So we have several deep techs on call, but we only have one nurse on call because the nursing offices won't mandate to pay for that. So now if you take a department that has not only trauma call, but also stroke call, I think that we need to have greater visibility at the administrative levels to fight for things that they look at the surgeons and just say, sure, that's logical, because they don't look at us that way.
I see John Opersuth, you're with us, and you're in a very vigorous private practice, I believe. How have you been able to balance the ability to cover intense call with the demands of your routine scheduled patients? Have you found a way to balance things?
Um, I think it depends on the culture of the hospital. I think the culture of the hospital, like our surgeons are just very cognizant of that we're only 3 IRs. And so for the most part, they won't call us overnight unless they know that for sure we're coming in, so we're not getting like, I remember being a fellow or even a resident getting just paged all night for little things because you're mostly dealing with other residents and fellows. But here, when you're in a more private practice setting, the surgeons are the attendings, and you have you're on a first name basis with relationship with them, and I think they're just more considerate, I think, in that sense, to not call unless you really go in.
I would say, just to add to that, John, is that, in the setting of trauma, it really is so unpredictable. One night you could be up all night, and then so the models, Herschel, it just doesn't really work, right? How many cases do you think is going to come in a week? Like, who knows, So what we need is redundancy, and that is just not something that we can do. And as I see that you're recording this, I'd be very careful with my words here. But I would just say that when Grady was at the brink of losing their trauma certification that was centered around interventional radiology. And if you ever come to Atlanta or you're in this area, you just drive on the highway, there are thousands of signs that says, I wouldn't be alive without Grady. I wouldn't be alive without Grady. And although it's a renowned stroke center and a renowned burn unit, there's a lot of trauma research that happens here. And so I definitely, along with Dr. Findice, who is the past president of SIR, who is the division chief of all of radiology for Grady, not just interventional radiology, we actually do exactly what Ezra says, or Neil says, we're at the table. And we're sitting at the table. Now, we may not be winning all the time, but we're making sure that we're not on the table for interventional radiology, right? That we're voicing these things. And so, yes, when there was a push, and there's still a push because it's in the recommendations, and we're there. There's an interventional radiology plan in the chart. Within 30 minutes of a trauma call, we push back and say, great, but who's going to pay for a technologist? Atlanta is such an incredible metro, and I'm sure it's true for some of the other areas that you live. Our technologists and nurses cannot afford to live near the hospital. So they live way out. And when they're hired here, they're not told that they have to be able to get back to the hospital within a certain amount of time. And so providing appropriate call rooms and staff rooms. Now, when I was in surgery, Ezra, I slept on the top bunk and there were two guys snoring on the bottom bunk, right? And that was just okay, just overnight. But I would tell you that, and I don't know these people, I'm just choosing their names here, Renee or Todd or Aaron and Fiona, they're not gonna want to live like that. They want better accommodations in the hospital. So Herschel, is more than just what the administration has to do. It really requires this investment. And one of the ways I think that interventional practices need to operate and think about this going forward, whether it's for trauma call or any call, is, what if we thought about our work like shifts? What if we tried to save ourselves by saying that I think that I can hand off this work to Herschel and I can go home. And therefore, he's going to be able to take care of this shift and I'm going to be back tomorrow. But the number one enemy of interventional radiologists doing that are actually interventional radiologists who believe that they can never leave and that Herschel is not as good as Ezra. And so they do not buy into this shift work that they can actually hand off work to another work. I will challenge all of you to think about that because it's a very important part of our well-being. It's an important part of the growth of the specialty. And if we don't address this, we won't get young people to come to interventional radiology, much less to want to do trauma.
think that was an excellent response. And I would just say in response to that is, it's not a perfect comparison, but clearly OBGYN does have some similarities to our specialty. And it wasn't until women became more than half of the workforce in OBGYN did they go from the model of being on call after working a full day, taking care of labor and delivery, to going to what you said, a shift-based model. And there was a transition time, and patients might not have fully embraced that the person that had been their doctor throughout their pregnancy might not be the one doing the delivery, but it sure has made OBGYN a more humane place for the providers. Neil, I might have cut you off. I'm sorry.
No, I was just gonna, I think that Dr. brought up another interesting point that I don't know how everybody is dealing with, but this is a continuing battle, given that we are in our trauma recertification window. And it is this decision by the American College of Surgeons that we have to respond within 30 minutes. And I think that when we talk about being involved in politics, it may be possible for doctors, trainees, nurses, techs to live in a reasonable, within 30 minutes, at a reasonable standard of living in much of the country. But I can tell you that that's a very hard rule to enforce in much of the big city America, the Northeast, and parts of, I'm sure, parts of California and around. And when we talk about being at the table, I think it's really important that our society and our practitioners are at the table, because we have to protect ourselves from other societies setting standards that may not be based in any science, that they're expecting to enforce upon us. And this is a situation where hospital administration could very rightly come to IR and say, we will not risk our level 1 trauma certification. You will be here in 30 minutes. And this is a problem. And I don't know how, I mean, you guys say you're now working a night shift, which is the answer. But until every hospital, has that as the answer, which isn't really the correct answer for every hospital, I think we need to speak up for ourselves in this issue.
Yeah, thank you, everyone. I mean, I think the night shift does sound like the right innovation for a big hospital setting, but for somewhere like Tufts that has 3 attendings or 4, Neil? Yeah.
Well, two. Well, we're down to 2. We're down to 2. It's busy.
Okay.
No, but no, what I'm saying, but even look at you guys, look at any hospital in the Boston area, to say in the Boston area that tech or a nurse can to work at MGH or at Leahy or at Tufts must live within 30 minutes. That puts you in a housing price point that is untenable for the majority of these people. I mean, just look at new hires, new staff hires at any of our hospitals. If they are in the Boston area trying to find a place to live when they're just starting out, it's very hard for them. And I think it's really very difficult to impose that. Plus, I don't know about you guys, but if I actually get onto the Pike, if I leave the hospital and actually get onto the Pike, I can't get back to the hospital in 30 minutes. Right? I can't get out to an exit, turn around, and come back in 30 minutes in most times. So.
Yeah, and I think it requires a lot of creativity there. And I just want to also point out that it isn't even tied to outcomes, right? So it is not that you have to even start the case within 30 minutes or than anything. It's just that
you just have to be there.
You just have to be there, and there is also subjected to change, right? Like what is there? And I know, for instance, in Chicago, they have used diagnostic radiologists that are in-house, whoever is reading in-house, to start their clock. But if you read the exact, we don't even have to go into that. It says, it has to be someone that is capable of actually, doing that case there, right? So, what is the capability of the diagnostic radiology? It depends on what year they're in. They could certainly be there to do the procedural timeout and maybe the initial angiogram. So there's a lot of stretching of those definitions. And I think we'll have to be a little bit creative ourselves and not stretch ourselves to a breaking point.
Well, I mean, this has been, I think, a very productive discussion about the challenges facing our specialty, even as we've, I guess, taken this tremendous opportunity to grow the role of IR and help patients. But now we're facing, I guess, the fruits of our success. I guess we should move on, unless there are other questions. I think we should move on to cases because it's almost 8 p.m. So Neil was going to give a brief presentation on this BARD recall, and then we have two case presentations from fellows at Brigham and BI. So I'll turn the screen over to Neil.
Let me unmute here and let me share a screen. I don't know if I just thought this was timely that there was just this announcement of the BARD PowerPort septum failure recall, and so the message just went out, and it was just very interesting that so here's the, let's see if it's going to advance here. There we go. Here's the urgent medical device recall for PowerPort duos and lot numbers. And this is a picture of what the problem is. And apparently the septa are coming dislodged with any forceful injections. And I just wanted to put this up because I don't know if any of you have seen this, but 3 days after the notice came out, patient we had put a port in came back to us because they were having discomfort when their port was being accessed and used, and it was swelling and they couldn't aspirate blood, and we injected the lateral port well, and here's a beautiful port ogram, and then we injected the medial port well, and this was accessed by an experienced nurse who felt the septum and the whole thing, and you look at that and it looks like the septum is displaced and it's leaking all around. So the patient went and had the port explanted, and there's exactly what had happened, which is exactly the picture that I showed you back here for the recall from what they had announced. So we're all seeing these. I see that Mike Stecker has said that they've had 3 to 4 failures. I hope that everybody is involving their risk departments. Just so you know, in the Commonwealth of Massachusetts, this is reportable to the state. This meets the criteria of serious complication, and although it's not a complication attributed to us, it meets the criteria for reportability to the state. So in addition to reporting it to BARD or MAUD, if you're doing it yourself, you need to be reporting these to risk management because they're going to have to report them. That's all I wanted to share.
Thanks, Neil. I know we're extra busy taking those out and putting in new ones right now. You mentioned Mike Stecker. The first case, we're gonna have Dan Bodmer present a case that he did with Mike Stecker because they're on call, so I want them to have a chance to present it while they're free. So Dan, do you want to go ahead and screen share?
Yes. Hi, everyone. Can you guys see it?
Yeah, I can see it, Dan. Thanks.
Hi, my name is Dan Bodmer. I'm an interventional radiology resident at Brigham and Women's Hospital, and I'm excited to present this case on a post-operative lymph leak with my attending Dr. Michael Stecker. So this case is about a 56-year-old female with atherosclerosis, which was manifested as aortoiliac occlusive disease and right renal artery occlusion. The patient underwent segmental aortic endarterectomy on the 15th of March of this year, which was complicated by a left retroperitoneal hematoma. She subsequently returned to the OR 6 days later on the 21st for a washout, and then developed high output from her JP drain that was milky in appearance and had elevated triglycerides up to 665 nanograms per milliliter. So the patient was initially managed with a low-fat diet, but she continued to have high output from the JP drain, and interventional radiology was consulted for lymphangiogram and possible embolization. So this is the lymphangiogram that we performed on the 25th of March, in which we injected Lipiodol solution into bilateral inguinal lymph nodes. Then it ascended superiorly through the pelvic and abdominal lymph nodes and lymphatic channels, right to the level of the surgical clips, in which you could see a lymphatic leak along the left side. It's important to note that the Lipiodol did not ascend superiorly beyond the leak, and it was in the correct location, adjacent to the surgical clips as well as the JP drain. And the nearest lymph node looked at it like it was at the superior end plate of L3. So at this point, we decided to not try to embolize this leak because it looked like there wasn't really a targetable lymphatic duct. The patient was only managed with a low-fat diet instead of being completely NPO. And then often injection of Lipiodol, which is very viscous, is therapeutic in and of itself without embolization and can slow these lymphatic leaks. So we told the primary team to make the patient NPO and put them on TPN and to continue to monitor the output. And the lymphangiogram and the NPO status did reduce the leak from approximately 3,000 milliliters per day down to 1,500 to 1,000 milliliters per day. But it still continued to be high output even with those measures. And they consulted us for embolization. So we started planning, for a possible embolization, and this was cross-sectional imaging, which showed a possible lymph node right at the level of the L3 vertebral body, which was, corresponded to the lymph node that we saw on the lymphangiogram. And it looked like it was most easily accessible from a left posterior approach in the prone position. So this is the scout image from the repeat lymphangiogram and embolization in the prone position. You can see that there's still Lipiodol on board from the prior procedure. And then this is a zoomed up image showing the target lymph node that we had saw on the prior lymphangiogram, as well as the cross-sectional imaging. So this is an AP view, and then a 45-degree left posterior oblique view with an overlying hemostat to identify this lymph node, which you can see here. And then in the left posterior oblique projection, we targeted this lymph node using an 18-gauge needle at the skin surface for increased stability, and then a 22-gauge Chiba needle through that 18-gauge needle, down the gun barrel, straight towards the lymph node. And the AP projection shows that the needle looked like it was within this lymph node. We did a Dyna-CT to confirm, the position of the needle. You can see the 18-gauge needle out here, and then the Chiba needle, which looked like it was right in the center of our target lymph node, with the Lipiodol from the prior procedure still present. So then we performed a digital subtraction angiography while injecting Lipiodol, and this is really a beautiful image here. You can see that the Lipiodol opacified the lymph node and starts opacifying the lymphatic ducts. And you can see these little droplets of Lipiodol, in the region of the stuck, which seemed a little bit abnormal, and then, just drifting into the retroperitoneum here, consistent with the leak that we saw on the initial lymphangiogram. And then this is a delayed image, of this Lipiodol injection. You can see this collection right next to the JP drain with these Lipiodol, droplets basically accumulating there. So then we decided to embolize the lymph node by, direct injection of a 5:1 NBCA mixture of glue, and we injected 3 mils. And you can see that the glue opacified this lymph node, opacified, the adjacent lymphatic ducts, and even you can see the darker glue overlying the area of the lymphatic leak. This is a subsequent Dyna-CT, showing that the glue opacifies this lymph node and was in the region of the leak. And this is a graph of the JP output over time. You can see that it was very high output on a high fat diet. When we performed the lymphangiogram and made the patient MPO with TPN, there was a significant drop off in the level of chylous output, down to 1,500 to 1,000 mils. And then we performed the glue embolization, and over time the output has decreased even further, down to under 500 mils. Although there's a little bit of variation, and has climbed back up slightly over the past few days. And that's it. That was the case.
An excellent case, beautiful images that you put together, and a beautiful presentation. Does anyone have any questions for Dan about that case?
I have a technical question. I haven't done cases like this before. You said that the Lipiodol is viscous. We know that. If you would have injected that and didn't demonstrate the leak, can you just inject regular non-ionic contrast that's less viscous to see maybe if you can demonstrate a leak that way, or is that something technically you shouldn't do?
It's a good question. I mean, I know I've only seen it where we inject Lipiodol. I mean, I know that I don't know if contrast would be transported in the same way, because it's a fatty solution. So I think it's taken up by the lymphatic ducts in a different way. But that's a good question. I know they used to use methylene blue, which was taken up by the lymphatics, but I'm not sure I know the answer to that.
I know I've read that at least, Lipiodol, at least when you do lymphangiography in the groin, it's not painful to the patient. I know that I've read that contrast is very painful, normal iodinated contrast, which is interesting. I think I've read that people do sometimes use iodinated contrast for this kind of like intra-abdominal injection to check. I think I read that in Techniques actually, Dr. Newsom, but I'm not sure. I don't know if Dr. Stecker's here.
Can you hear me, Ezra? Can you hear me?
Yeah, I can hear you. Yep.
Okay, I guess the microphone works. I have no camera, but so I think maybe you could have used regular water-soluble contrast for the lymph node injection. When they stopped making the original Lipiodol that we used to use for the pedal lymphangiograms back when we did the pedal lymphangiograms, I once tried doing a pedal lymphangiogram with water-soluble contrast, and it did not work out well because it comes out of the lymphatics and just gets in all the tissue. So that to do a lymphangiogram of any sort of distance, you really need the non-water soluble, the fat soluble, so that it stays in the lymphatics. But probably if you were, I probably could have just injected water-soluble contrast directly into the lymph node, and it might have worked. But since we have, the ethiodol, that's what I used. It's also denser, kind of gives you a better target, and it does stick around, which kind of worked from the first lymphangiogram to the second one.
My question is, what now? Are you satisfied with 500 a day? Oh, what are you going to do now?
So we are going back and forth, I think, with the surgeons. They're asking, is there something more we can do? I'm not really sure that there's more we can do. I guess, I said we could maybe target another lymph node and see if there's still some leak from another lymph node, but I don't know how many times you're going to try that. He's come down twice, and the output is coming down. So sometimes, we find even with the thoracic leaks, you got to give them a little bit of time. But I agree that is kind of becoming more than just a little bit of time. So we may try it again. We'll have to see.
Great. Thank you, Mike and Dan. We have another presentation. And this is going to be Bashar Nahab from Beth Israel has a case to present. So Dan, if you could stop screen sharing, and then Dr. Nahab can start screen sharing.
Okay, thank you.
Hello, everyone. Can you see my screen?
Yep, looks good.
All right. I'm Bashar Nahab, one of the interventional radiology residents at Beth Israel Deaconess. I am presenting a case or a case and a case companion. These cases were supervised by Dr. Marwan Musa and Dr. Munib Ahmed. The case that I'm going to present is a little bit different than the scope of the trauma today, but it's really for extravertebral osteosynthesis with cementoplasty and cryoablation. The reason why I chose these two cases because this method of treatment or palliative treatment for those patients, it represents a tremendous way of improving morbidity for cancer patients. And it's also a good example of two services collaborating for patient care. In this case is orthopedics and interventional radiology. I don't have any disclosures. So first case is 87-year-old female with a bronchial invasive squamous cell cancer. New onset of left hip pain. Pain is really severe, 10 out of 10, with movement about 7 out of 10 at rest. Patient cannot ambulate or bear weight. Initial imaging showed CT pelvis showed 2.5 centimeter low-level lesion involving the left acetabulum. And there was evidence of element of component of involvement of the cortex. Just for further iteration for patients' pain, patient is on hydromorphone 2 to 4 milligram Q4H and also on gabapentin. Labs and meds, nothing really pertinent, but just for completeness, I included the hemoglobin, platelets, and creatinine. Patient was apixaban for AFib that was top prior to procedure. This is the initial CT, which shows that there is a left acetabular, about 2.5 centimeter metastatic lytic lesion. This is the axial and the coronal images. And you can see on the axial images, as pointed out by the red pointer, there is involvement of the cortex, which is it's kind of important to note because these metastatic lesions represent an impending risk for pathological fractures for those patients. So we have two issues for this patient, patient with severe pain, patient with rest pain and pain with bearing weight, and there is impending risk for fractures, pathological fractures. We were consulted for palliative treatment. So in collaboration with orthopedics services, what we do, we did osteosynthesis for these patients and with cryoablation and cementoplasty. This is a cone beam CT images. And we start, as you can see, this is just to replicate the images, cone beam CT, same lytic lesion as pointed by the red pointer. We start usually for these cases, we start with cryoablation. We have, this is a 17 millimeter, 17 cryoablation probe that's located within the isocenter of the metastatic lesion. In this case, we did 2 freezing cycles. And followed by active thaw. Following a cryoablation, and this is the innovative way, relatively innovative way of treating those patients with the cannulated screws, and these are placed over the Krishna rods And this procedure is done under general anesthesia in the IR suite. So these, you can see the screw passing through the metastatic lesion. Following placement of the screw, we do use the balloons, a 15 millimeter balloon to create space around the screws so that we can do cementoplasty that will overdrape the tract of the screws. This is 2 pictures of the procedure. So the image on the left, this represents the initial image upon presentation. You can see the lytic lesion as pointed. And just for comparison clinically, patient had 10 out of 10 pain. Patient was on hydromorphone and unable to bear weight or move. Post cryoablation, we do follow-up for these patients, sequential follow-up after 3 days, after a week, and then after a month. And after a month, we can see the patient went down from 10 out of 10 to 1 out of 10 pain, able to ambulate and bear weight. It transitioned to tramadol of hydromorphone. So in conclusion for this case, in addition to significantly improving morbidity for these patients, we also preventing impending fractures for these patients. A companion case, very similar, 59-year-old male with metastatic RCC, status post combination of treatment, patient with right hip pain, CT showed up to 7 centimeter lytic right acetabular metastases. As you know, a lot of physical exams gone through telehealth. So in this case, we evaluated the pain. Evaluation of the pain, whether it's at rest or during movement, is extremely helpful, and for assessment, evaluation, and for follow-up as well. And this patient had up to 7 to 8 out of 10 with weight bearing. This patient specifically was refusing narcotics, and he was relying on NSAIDs for pain control. Labs for completeness was included, but nothing really pertinent for this specific case. So this is pre-procedural CT. See a large, up to 7 centimeter, 5 by 7 centimeter right acetabular lytic lesion. And here, the cone beam CT showed also cortical involvement. As I mentioned before, this is more risk for impending fractures, pathologic fractures for those kind of lesions. Again, we started with cryoablation. In this case, is a larger lesion. So we placed 3 cryoablation probes. Of course, we monitor the cryoablation under cone beam CT. We want to make sure that the joint is not involved, or minimal involvement of adjacent tissue, and also the nerves around in that region. And then as you can see, the Krishna rods were placed, and the cannulated screws were placed over the Krishna rods, and the K wires were removed eventually. And then we did the balloon expansion, then followed by cementoplasty. And the idea, as you can see, the cement circularly kind of drapes over these screws. This is post-procedural images. And you can see it's a beautiful image of like screws and the cement just going in parallel and draping over these screws. And that's basically to prevent future fractures. This patient was discharged after 24 hours, referred for physiotherapy. Unfortunately, in this case, we did not have as great as outcome as the first case. He developed a second metastatic lesion on the other side. So focused literature review in these cases. So it's known that cryoablation helps with metastatic lesions. Percutaneous cementoplasty also relieves up to 90% of the extravertebral lytic metastases, averaging 3 centimeters in size. The combination of osteosynthesis, cryoablation, and cementoplasty is a novel way. It's relatively novel. There is a group in France. They've been developing this a form of palliative treatment for patients over 5-6 years from now. And this is a nice article that's published also by Dr. Duchamps. So this is the French group. And they have a larger group. They have up to over 80 patients, and they compared the pain pre and post procedure. they compared it and showed significant improvement, and they measured the pain based on VASC score. So you can see the pain significantly improved from 75 to 10, 80 to 25 for osteoporotic and pathological fractures. So in summary, so osteosynthesis with cementoplasty, safe and effective in relieving pain and preventing fractures. Required for accurate pain assessment is really important for assessment of the patient, candidacy of the patient for this kind of procedure, and for follow-up as well. It's also in France, this group, the percutaneous screw placement were performed solely by IR. In our hospital, we do it in a multidisciplinary setting with the orthopedics services as well. And again, it significantly improves morbidity for these cancer patients. These are the references. Thank you for listening. If you have any question, I'm available.
Excellent presentation. I really enjoyed that, and beautiful images. I recently did a case similar to your first one, actually, but I didn't use a screw. And Michael Merports wrote, is a screw necessary? Do you think ablation and cement would just be sufficient? I think maybe particularly for the first case with the smaller lesion.
Sorry.
So the question is basically, do you think you need a screw for smaller lesions such as the first case that you presented, or how did you choose to use a screw in addition to cement for that case?
Oh, okay.
So go ahead, Bashar.
Yeah, so as far as for cement, so for screw placements, there are different things. For my case was for a lytic metastatic lesion. Based on the literature review, placing screws will prevent future impending fractures. There are other indications for screw placement, which is pathological, as in my case, if there is an actual fracture, or there is insufficiency fractures. And when you have insufficiency fractures, you can just place screws. Actually, is more important than the cement itself, because the cement will not tolerate wear and tear in rotational movements in places like the sacrum itself. So the screws can be actually, in some cases, more important than the cement itself. And I'll defer to Dr. Moussa if you want to comment on that, if you have anything to add.
Yeah, Ezra, can you hear me?
Yeah, I can. Hey there.
So yeah, just to add on what Bashar said. So when it comes to the pelvis, if it's small, posterior acetabular, typically it'll suffice that one can do a cryo with cement. Once it comes more along the roof or anterior, and there's more weight bearing associated with it, and a lot of rotational and shear forces, then a screw typically is also indicated. And again, we do this as a multidisciplinary conversation that we have with our orthopedic colleagues in Sarcoma Conference. So it's a joint decision that we make together.
Excellent, thank you. And you're doing this in a regular angio suite just with cone beam?
Yes. So actually, we will do with cone beam, and it'll be an initial cone beam using navigational software. And then once, typically, if they put in a screw, that acts as our fiducial marker in some sense, and we're just able to continue the rest of the case without CT and without navigational software. So yeah, they tend to be interesting, but definitely we've learned the hard way that we need to budget a lot of time to do this. There's a lot of moving parts for these cases, and especially if there's going to be any like critical structures like the sciatic nerve close around or anything like that, and then you're involving the neural monitoring as well. So there's a lot of moving parts and planning that goes ahead to try to smoothen a case like this out.
Cool. Yeah, the one I did neural monitoring, it definitely added a lot of time, but maybe I can find a way to watch you do one with this screw at some point. So thank you very much. It's great presentation.
Absolute pleasure. Would love to have you over, Ezra.
All right, thank you. Any other questions for this presentation? All right, well, the floor goes back to Dr. Newsome, who has the difficult decision of choosing the best case award for the evening.
Yeah, so those were two amazing cases. Dr. Musa, I'm going to ask you to get the Avail system into your institution. That way I can watch your next case. I realize that I've been doing a disservice to the patients that I've just been ablating and putting cement in. And maybe I need to take my orthopedic friends out for drinks once the pandemic is over and start a new collaboration. But I think both presentations were amazing. I share offices down across the hallway with Dr. Majdelaney. And I think maybe it's a true interventionalist in me that always like a really, really difficult problem. And I think that lymphatic leaks, especially in the retroperitoneal after surgery, continues to be something that plagues interventional radiologists. And I can't wait to be invited back to the next presentation to find out what else did we do for it. And so I think that although both presentations were exciting, I'm actually going to choose the lymphatic presentation, because it's, again, maybe it's because this has just satisfied my thirst already, Bashar, and I'm coming up to watch you do it and hope I can get your number so you can teach me how to do it. But lymphatics, I think, continue to be an area of interventional radiology that we yet need to know what to do with it, right? We are working in the arterial system, venous system, we work in biliary system, urinary system, and the lymphatic system continues to be something that is fascinating, and we're going to need to know more about how to treat it. So.
Congratulations, Dan.
Thank you. I very much appreciate that. And thank you, Dr. Stecker, for the great case.
Excellent. And just a couple of notes before we finish. Our next meeting is scheduled for May 10th. It was going to be an in-person simulation session that Dr. Salazar was going to lead. Unfortunately, we're still under a lot of restrictions with COVID, so that will be delayed till the fall, and will hopefully be a big event that Shams Iqbal is going to set up with industry, and Dr. Salazar will also work with simulation. So May 10th is still our next meeting, and we're just figuring out exactly finalizing the talk. So with that, thank you again, Dr. Newsome, for speaking tonight. And it was wonderful. So.
Thank you so much.
Thank you for having me. This was amazing. Thank you.
Thanks, everyone. It was amazing. Great cases, great talk.
Excellent.